Welcome everybody to the program entitled Advances in the Treatment of Myelofibrosis. This is clinical trial data of next generation therapeutics. My name is John Mascarenhas from the Icahn School of Medicine. I'll be joined today by my friend and colleague Rajit Rampal from Memorial Sloan Kettering Cancer Center. Importantly, this educational grant comes from both Geron and Insight to support this activity. This is a CME accredited program, so here's the information, the accredited statements both for physician and nursing credit, nurse practitioners and PAs. This is a Haymark Medical Education program by CancerNet. You will receive a certificate. To get this certificate, please ensure you attend the entire webinar, and then at the end there's a brief evaluation to download your certificate using the link provided at the conclusion of the program. You have to do this before June 13th. We will discuss, and we are disclosing off-label use of agents. And we have provided our disclosures as well, according to ACCME policy. And here are our disclosures on top for myself, below for Dr. Rampal. The learning objectives for today are to illustrate the pathophysiology, myelofibrosis symptom burden and risk stratification in selecting MF patients for optimal disease management, and to develop strategies for risk-informed NCCN guideline-directed therapies and next-generation therapeutics for the treatment of myelofibrosis. This is the agenda. We'll start with a pretest poll question. Then we'll get right into the didactic for about 30 minutes, which is an overview of the pathophysiology, symptom burden, risk stratification, molecular profiling. I'll handle that. There'll be a post-test poll to assess learning, and then the same format for Rajit's presentation, which will go into the guideline-based treatment options. And then at the end, time permitting, we'll have a panel discussion as well. We really look forward to any kind of engagement and questions from the audience. So let's go with the first pretest clinical vignette. So this is a 63-year-old woman with CALR positive primary myelofibrosis diagnosed about a year and a half ago, comes in for follow-up with just watchful waiting approach. She now complains of increasing fatigue, bone pains in the lower extremities at nights, moderate night sweats, and early satiety. The CBC is notable for a white count of 15,000, a hemoglobin of 8.7, and platelets of 499, 1% blast on manual review. On an exam, she has some mild temporal wasting and palpable splenomegaly, about 8 centimeters below the left costal margin, with tenderness on deep palpation. So in this patient, what clinical risk variable holds the strongest adverse prognostic influence in this patient? Is it A, hemoglobin, B, blast percentage, C, age, D, spleen size on exam, or E, systemic symptoms? Please choose the most appropriate single response. All right, beautiful. So we'll repeat this question at the end of this initial didactic, and we'll go from there. So I'm going to do the overview. As I said, this is the schema as we look at MPNs in 2025. We separate the pH positive, which is CML, to one side, of the pH negative classic MPNs or myelofibrosis, polycythemia vera, essential thrombocythemia. There are other non-classic MPNs that are even more rare actually, but the three classic ones that we typically talk about that are pH negative are MF, ET, and PV. They're interrelated, both from a biologic standpoint with clinical feature overlap too. One central theme of MPNs in general is overactivation of the JAK-STAT signaling cascade, and this can be activated through multiple mechanisms, whether it's a point mutation in the JAK2 gene at exon 14, or mutations involving calreticulin, a multifunctional protein that associates with the thrombopoietin receptor, or the thrombopoietin receptor itself, which is the MPL gene. No matter which mutation drives the disease, those are driver mutations, the consequence internally is this activated STAT signaling system within the malignant or clonal population that drives both the inflammatory response and the propensity for cellular proliferation. There are obviously diagnostic criteria. They're updated every several years, most recently in 2022. Here I'm showing you the ICC diagnostic criteria. And you'll see the major on the left, you need a bone marrow biopsy. And I see frequently patients don't get a bone marrow biopsy. It's assumed they have one of these, and they may not have any of these. They could have MDS with myelofibrosis. They could have other related myeloid malignancies, including AML. So a bone marrow biopsy really is key to the diagnosis. You want to document usually a hypercellular bone marrow. These are myeloproliferative neoplasms with characteristic megakaryocyte atypia, usually tight clusters of megakaryocytes, and in a background of distortion of the architecture from reticulin and collagen fibrosis, at least grade 2, if not 3. A clonal marker of disease, JAK2, CALR, MIPL, or a cytogenetic abnormality. You want to rule out reactive myelofibrosis, whether it's connective tissue disorders, inflammatory diseases, infectious complications, other malignancies, lymphoma, myeloma, leukemia, MDS can all have fibrosis. The fibrosis is not specific for the diagnosis of the MPN myelofibrosis. And then you want to make sure that you're not really looking at a CML, so make sure the BCR-ABL is negative. And that the patient meets the criteria for myelofibrosis without meeting criteria for other related MPNs or myeloid diseases. And then usually a minor criteria is present. Almost invariably, these patients have anemia, if not at presentation during the clinical course, leukocytosis, palpable splenomegaly from extramedullary hematopoiesis, and LDH reflects the proliferative capacity of this clone, and then leukoerythroblastic blood picture, early myeloid cells in the blood, nuclear red blood cells, blasts, and forms prior to maturation. Those cells should mature in the bone marrow and only come out as mature forms. But in MPNs, particularly myelofibrosis, this phenomena of early egress is a hallmark feature of the disease. There are diagnostic criteria for both PV and ET-related myelofibrosis. I won't go through all of the details, but be assured that they are there. And obviously for PV-related MF, you need a prior diagnosis of PV to have established the patient as post-PV MF. Similarly, you need an ET diagnosis, and you have worsening fibrosis and then worsening disease state as shown in the additional criteria. MPNs in general are rare diseases by NCCN, NCI guidelines. Less than 4 cases per 100,000 constitutes a rare cancer. The incidence of myelofibrosis here is probably somewhere around 1 person per 100,000. It's likely underestimated because there really isn't a great database system, at least in this country, to truly capture the true incidence, I would say, of this disease. But if you were to add all of these MPNs together and include AML, which could be the natural history of any of these MPNs, it's about a third of all hematologic malignancies. The key hallmarks and clinical presentations of MF are summarized in this slide. And there's a triad of cytopenias resulting from bone marrow failure, constitutional symptoms which are driven by cytokines, and splenomegaly due to aberrant trafficking of stem cells leading to extramedullary hematopoiesis. These patients are quite symptomatic, and that's a major aspect. It's a major goal for intervention for these patients, as the symptom burden can be quite large and debilitating and lead to reduction in both quality and quantity of life. And anemia is a major aspect of this disease. Much like MDS, these patients are frequently anemic at baseline and then progressively get anemic during the clinical course as a hallmark and a feature of disease progression. So there are multiple aspects of the disease that relate to the understood biology that drive on the right the splenomegaly, the symptoms. The fibrosis is a consequence of overproduction of inflammatory and fibrogenic cytokines like TGF-beta from megakaryocytes and monocytes to the cytopenias. And again, you'll see the concept of anemia. That was the pretest question. Anemia is a very common and complicating feature of this disease process. This is a sort of a dramatic picture. This is from a long time ago. You really don't see this as much anymore because of the advent of JAK inhibitors, but you would see these patients with very large spleens and livers outlined by the marker on this patient on the left. leading to ascites often with portal hypertension, and as you can see in this patient, cachexia and wasting. The picture here is probably not the best picture. I always use this picture, but it's supposed to indicate on the left a nuclear red blood cell, early myeloid forms, thrombocytopenia. You can see anisocytosis of the red cells. And then if you look at the bone marrow in the corresponding patient, it is usually fibrotic. There's distortion, and then as time goes on, there's less myeloid cell development in the bone marrow, as it almost exclusively occurs outside of the medullary space. Um, Symptoms, as I mentioned, are part of the problem of this disease, but all of the features of disease lead to reduction in quality of life, whether it's vascular events, which are quite common in this setting, progression, and or the risk of progression is very anxiety provoking to AML or overlapping disease with myelodysplastic syndrome. They often have second primary malignancies like lymphomas, myelomas, kidney cancer, liver cancer. That's been well documented, and is an intensely inflammatory disease, perhaps more inflammatory than classic connective tissue disorders, cachexia, wasting, fevers, night sweats, profound fatigue, and global weakness, and even cognitive dysfunction is well described. The cytopenias lead often to transfusion dependence, and the addition of other medications to try to address the anemia, and obviously contribute to poor quality of life. And then if you have a large liver and spleen, that's not only uncomfortable and disfiguring, but also leads to other complications like both portal and pulmonary hypertension from extramedullary hematopoiesis. This slide is supposed to characterize the impact of the symptoms on quality of life. It's from two cohorts, a U.S.-based cohort in blue, and then in gold, an international cohort. It's supposed to, and forgive the formatting, it got a little messed up here, but it is supposed to convey that these diseases are really symptomatic diseases in large part. And perhaps, for example, in blue, there are more symptomatic patients from a fatigue perspective in the U.S., which might be multifactorial and beyond the disease, but fatigue is clearly a major symptom in every study. It comes up as the number 1, 2, and 3, both in terms of frequency and intensity. Obviously, fatigue is complex, it's multifactorial. It can be driven in large part by the anemia, which is prevalent, but it can be also due to a lot of the inflammatory sequela of the disease, and the anxiety of having a chronic yet progressive disease. But the slide is supposed to impact or promote the concept that these are symptomatic diseases. One needs to be aware of the symptom burden in order to be sensitive for the need for therapeutic intervention in many cases. And this leads to reduced quality of life. Very well described that patients with these diseases end up taking themselves out of both work and social activities, so it starts to curtail their productivity, and their sense of well-being is very much in jeopardy. And you can see this in the patients that we treat, that they are often emotionally, psychologically also burdened by having this chronic progressive disease. And it is progressive. It can progress in different ways. So sometimes we say MF is a progressive disease, but it can progress both from a cytopenia perspective, a systemic symptom perspective, a spleen and liver perspective, a vascular perspective, and then sort of the most concerning and probably the one that really frightens patients the most is the potential to transform to an acute, usually acute myeloid leukemia. Sometimes it's ALL, acute lymphoblastic leukemia, but it's almost usually myeloid leukemia. And the median time to transformation, can be several years, but we've seen patients progress within months of the diagnosis, and the progression to AML is essentially a terminal diagnosis at that point. And conventional therapies don't meaningfully impact AML therapy. In this setting, this behaves much worse than de novo AML, with a median survival somewhere between 3 and 5 months. Now, back to chronic phase disease. If you look at this black line, which is the age and sex matched population of patients, of people who do not have these diseases, the median age of diagnosis is 65. But you can see that the median survival of an ET population is about 20 years. PV, it's about 14 years. And then for MF, it's closer to 6 years, let's say. So it is clearly a disease that impacts quantity of life. Now, I keep mentioning cytopenias, that's a prominent aspect of the disease. Up to two-thirds of patients with myelofibrosis have cytopenias at diagnosis. Almost 90% we're going to have cytopenias through their course. You can see the percentage, and if one thinks of raw numbers of patients in the US, 21,000 living with this disease, there's a significant burden of cytopenias within that 21,000. And patients with cytopenias do not do well, and they're harder to treat. That's why we emphasize and often draw out the fact that this is, much like MDS, this is a disease of bone marrow failure and cytopenias, which both are related to prognosis and complicate therapeutic intervention. The deeper the anemia, the worse the outcome. This is from an Italian study demonstrating that patients with a median survival, patients with a hemoglobin less than 8 grams per deciliter or transfusion dependent have a median survival of 2.1 years compared to those that do not yet have anemia with a projected survival of 8 years. If you just segregate the patients by transfusion dependence or independence, transfusion dependent patients clearly do worse. So needing transfusions is not just poor quality of life, it's also a predictor and a risk factor for survival. So depth of anemia, transfusion dependence, adverse prognostic markers. Thrombocytopenia, also a very sensitive marker for poor outcome. In this study by the MD Anderson group, median survival was only 26 months, so 2 years, if the platelet count was less than 100,000. Versus 57 months if it was greater than 100,000. And again, the depth of thrombocytopenia, as you can see from the graph below, also correlates with worse survival, so inverse relationship. And the depth of thrombocytopenia also predicts for worsening anemia, which of course is a adverse prognostic marker, greater degree of fibrosis, and risk for leukemic transformation, which is clearly associated with worse outcome. There are many ways to risk stratify patients. This is the DIPSS, the Dynamic International Prognostic Scoring System. It was based off of the IPSS, which was used at the time of diagnosis. DIPSS can be used dynamically at any time. It incorporates advanced age, leukocytosis, anemia, keeps coming up, independently influencing outcome, peripheral blood blasts, and systemic symptoms. And you get these risk categories. And of course, you don't need to memorize any of these things. They're, you go to UpToDate or online. You can find the calculators and just put your patient's information in, so that makes it very easy. There's the DIPSS Plus, which then capitalizes off the DIPSS but adds thrombocytopenia, transfusion need, as I showed you, and unfavorable karyotype as risk points. And again, this contributes to a more refined risk stratification tool. I'm going to go back one slide just to make a point that I don't know that I actually made, but you'll notice that a hemoglobin less than 10 is heavily weighted here, 2 points. So just keep that in mind. That's probably the most potent risk variable. And that's true. It just keeps coming back with each risk scoring system that's made. Mutations matter. So we went from clinical variables, adding to cytogenetic abnormalities, and then mutations matter. We know that patients with triple negative disease, these patients in the black line, they do the worst. So they lack JAK2, CALR, MPL. And the patients that seem to do the best are the CALR mutated patients with a median survival of 17 years, and the triple negative with 3.2. The JAK2 MPLs are kind of in the middle with a median survival around 9 years, at least in this one study. We see the same mutations essentially that we see in AML and MDS in this setting, whether they're spliceosome mutations or epigenetic alterations. And here, the study identified 4 mutations specifically that were associated with poor outcome, which we now call the high molecular risk mutations. That's EZH2, SRSF2, ASXL1, and the IDH1 and 2 mutations. P53 always gets a lot of attention. It's not frequently mutated in the chronic phase, probably around 8%, much more likely to be mutated in the leukemic phase. And there's data that if you have homozygosity or if you have multi-hit P53, so that's a VAF greater than 50%, or a P53 mutation with 17p deletion, which is where the P53 gene sits, or P53 mutation with loss of heterozygosity, then you have a very poor outcome situation. uh, no matter how you slice and dice the disease. And that's really true of any disease, not specifically myelofibrosis. But multi-hit P53 is clearly a poor prognostic marker. So you can incorporate these HMRs into risk stratification, which is what the MIPSS-70 version 2.0 does. Again, you can see, anemia keeps getting in there, and severe anemia in particular gets 2 points in this scoring system. But the absence of calreticulin type 1 mutation that's adverse, high molecular risk mutations, having 2 or more, unfavorable karyotype, very high risk. And again, don't need to memorize any of this. You can just go to the calculators online and put your patient's information in. There are disease-specific risk stratification tools. So the MYSEC is for secondary myelofibrosis, whether it's ET or PV, and you'll see very similar, variables, including hemoglobin less than 11 for as a risk factor, as an adverse prognostic marker. So a little bit higher threshold, but acknowledging anemia as a potent adverse prognostic marker. So what do we do with all this information in terms of the current treatment of myelofibrosis? And Raji's going to get into greater detail. But essentially, we risk stratify patients, and whether they're symptomatic or asymptomatic helps to drive therapy. Asymptomatic, no anemia, low risk patient, you can watch that patient. That's NCCN endorsed. I would say that's a small number of patients. Most patients are not low risk, and even if they are, they often do have spleen burden and symptom burden and to some degree anemia. Of course, if it's significant enough, then they're not low risk anymore. And if anemia is really the therapeutic goal, there's ESAs, luspatercept, which we'll talk about, which is an activin ligand trap, not yet approved for myelofibrosis. We'll have to see more of the granular data from independent study. And then danazol, which is an old drug, a male synthetic androgen, that can also help with anemia. There's a number of drugs in development, but our armamentarium right now is kind of limited actually for anemia. And then if the patient's symptomatic and has spleen, that's the targeted therapy. You've got the 4 approved JAK inhibitors, and then a number of drugs in development, either as single agents or combination partners with those JAK inhibitors to try to induce better spleen and symptom response. The 4 JAK inhibitors, to sort of set the platform, are listed here. Ruxolitinib, obviously the first one, equipotent JAK1/2 inhibitor, approved in 2011, and then fedratinib in 2019. It's more selective for JAK2. It's also a FLT3 inhibitor, so you have more GI toxicity with this drug, very potent drug. Wernicke's encephalopathy is a black box warning, just be aware of that. It's the only one. Just check vitamin B1, thiamine levels, and replete. Pacritinib is a multi-kinase inhibitor. It spares JAK1 totally, and it hits IRAK1, which is important for NF-kappa B, which a multifaceted NF transcription factor, ACVR1, which mediates hepcidin, and FLT3, so you can get some GI toxicity. This drug is approved for patients with lower platelets, which is a significant unmet need. And then momelotinib, which is a equipotent JAK1/2 inhibitor, like ruxolitinib, but like pacritinib, hits ACVR1, associated with more effect for anemia. Now, patients who are on ruxolitinib, which is a great drug, it's first and best in class, still don't garner all of the benefit in an enduring way. Ultimately, most of those patients end up coming off therapy. The median time to discontinuation, I'll show you in a slide in a second, somewhere between 2 and 3 years. So it doesn't take them the distance. And the reasons for coming off are listed here from Dr. Palandri's paper from about 5 years ago, demonstrating lack of response, loss of initial response, ruxolitinib-related adverse events, and that could be infection, squamous cell carcinoma, cytopenias driving that, worsening cytopenias. Only a fraction of patients, unfortunately, actually go to something that is potentially curative, which is transplant. And yet still some patients can, while benefiting from ruxolitinib from a spleen and symptom perspective, can transform to AML, which totally changes the treatment approach. And I guess tells us also that ruxolitinib is not, or any of the JAK inhibitors, are not really fundamentally changing the natural course of the disease, which is a limitation. Multiple studies show us by 2 years, 3 years in the COMFORT study, half the patients are off therapy for one of those reasons that I showed you. Mutations matter, not just prognostically, but also therapeutically. So if you have a high molecular risk mutation, particularly ASXL1, or multiple high-risk mutations, even more so, you have a shorter time to discontinuation. You enjoy the benefits of ruxolitinib to a lesser and a shorter degree. So the molecular complexity of the patient also impacts response to therapies, namely ruxolitinib publication. There are tools that can be used. This is the RR6 that can help you get a sense of where your patient with ruxolitinib sits in the grander scheme of things. Maybe to help formulate discussions about transplant. So in this Italian study that validated then at the Moffitt Cancer Center, demonstrated in independent fashion that the need for red blood cell transfusion dependence, again anemia, spleen length reduction less than 30% by palpation, or ruxolitinib doses less than 20 twice a day, which is the majority of patients with myelofibrosis on Rux within a 6-month period, adversely influence outcome. So if you add those up, you can put patients into discrete risk groups: low risk, intermediate, high risk. And again, you can see the calculator online, so you don't need to memorize any of this. But you can see that patients who fall in the high risk category, even on Rux, even while enjoying some degree of benefit, if it's not the full benefit, you can't get them to adequate doses of Rux, and they're needing transfusions. Those patients are not going to do well in the long run. That might be the patient that you may try to move towards transplant in a relatively shorter period of time. I said this multiple times now that the outcome is poor. In one retrospective single center study, it was only 6 months once you fail ruxolitinib, but most of the studies have it somewhere around a year to maybe a year and a half. And no matter whether it's single center, multi-center, or claims-based studies, this is really a problem for the patient. So it really begs the question: who should get a transplant? I think if patients are particularly under 65, but I would even say under 70, and their risk score, whether it's DIPS, MIPSS, or whatever, is expected to be less than 5 years. That's usually intermediate 2 and high-risk disease patients. Those are patients really who should be exploring transplant. And or patients who have lower risk disease, like intermediate 1, who are younger, but have circulating blasts, have anemia, transfusion dependence, or even have some of these high-risk molecular markers, whether it's triple negativity or ASXL1, P53 mutated. We could have a discussion about whether it even makes sense to transplant a P53 multi-hit disease. But those are the patients you would really want to make sure that have seen a transplant or have had that discussion and consider transplant as the only curative modality. The reality is less than 10% of patients actually get a transplant with myelofibrosis. And some of it historically had to be just referrals weren't made, but also donors weren't available. Now we are much more likely to use even an unrelated single mismatch donor or haploidentical from an adult child of that patient. And even a lot of the centers have studies with cord blood, double cord blood transplants too. And I have to say the transplant outcome since I've been in this field for almost 20 years has definitely gotten better in terms of reduction and management of graft versus host disease, as well as the supportive processes of antimicrobials and immunosuppressive therapy. And JAK inhibitors are now used even for GVHD as well. So the outcomes for myelofibrosis have improved, but it's really personalized and should be seen at a center that has a high volume. So in conclusion, myelofibrosis, it's a stem cell derived blood cancer with overactive JAK-STAT signaling at the core of the disease process. That's why JAK inhibitors were developed. It's an inflammatory disease with significant symptom burden that ultimately is associated with debility, reduction in quality of life, and reduction in quantity of life. And risk stratification tools exist, multiple of them, they're all online, including integrating clinical and molecular determinants of adverse outcome to help categorize our patients by expected survival in order to make decisions maybe about transplant. And then interventions outside of transplant, which is the only curative option, really are focused on reducing spleen and improving symptoms and alleviating anemia. And although I'm a fan of JAK inhibitors, I have to acknowledge, they are insufficient alone to remit this progressive hematologic malignancy, and the next generation of clinical trial exploration is on combination therapies to improve upon the backbone of therapy. So I greatly appreciate the opportunity to join this program today with Rajit. And before I end, I'm going to go back to the post-test clinical vignette. Again, this is the 63-year-old lady, CALR mutated, primary myelofibrosis, disease for about a year and a half, had been watching because the patient was not symptomatic enough, didn't have significant anemia at that time, but now she has increasing fatigue, bone pains, lower extremity bone pains at night that really affect quality of life and leave her fatigued. She's drenched in night sweats. Her spleen is getting bigger, early satiety, 15,000 white count, hemoglobin 8.7, platelets 499, 1% blast on the smear, and she looks ill. And her spleen is 8 centimeters, very easy to palpate on exam, and tender. So, what would you do with this? Not what would you do, but rather, in this lady's case, what clinical risk variable holds the strongest adverse prognostic influence in this patient? Is it hemoglobin? Is it blast percentage? Is it age? Is it the spleen size? Or is it systemic symptoms? Please choose the most appropriate answer.
Please vote if you can.
All right, fantastic. So um, it looks like 50% of today's participants picked hemoglobin. I would say that's the right answer. I mean, I put that in because the risk scoring systems that were derived by multivariable analysis of looking for independent prognostic variables in different cohorts of patients all have the same thing in common, anemia. And multiple studies show the depth of anemia also associates with outcome. And for example, in the DIPS, it's the most heavily weighted prognostic variable. So, although I would say all of these contribute to risk, if you were to ask me which is the most, strongest adverse prognostic influence, it would be anemia. I wouldn't say blast percentage only because blast percentage in itself, is a risk variable. And maybe that's an unfair one because if you have like 15% blast, that is a poor prognostic marker. But I'm talking about patients in chronic phase disease that don't have that kind of blast percentage. So I think that ends it for me. I am thrilled to hand it over to my buddy Rajit Rampal, who's going to go through the second half of this presentation. Thank you.
Terrific. And there will be some content that overlaps a little bit in terms of prognostication and whatnot, but I think that's actually useful to hear this a couple of times. So we'll start with a case vignette. And here we have a patient who is a 76-year-old male presenting with fatigue, weight loss, and abdominal fullness. Exams noted for a pretty large spleen, 12 centimeters below the left costal margin. And blood counts are notable for a white count that is normal, but 3% circulating blasts on the smear, hemoglobin of 10.5, and platelets of 181. The marrow shows findings consistent with myelofibrosis, including MF3 fibrosis, so that's at the highest end of fibrosis. Cytogenetics are normal, and the NGS panel shows the presence of a JAK2 mutation and an ASXL1 mutation. So the patient is diagnosed with primary myelofibrosis, and the risk stratification here by the different scoring tools includes DIPSS intermediate 2 and MIPSS-70 very high risk. So what is the appropriate choice of treatment in this patient? So lenalidomide and prednisone, pegylated interferon, fedratinib, ruxolitinib, pacritinib, or either C or D. Okay, great. We will come back to this question at the end. So, as I said, we're going to talk about the therapeutics in a little bit more detail, and I'm going to try to put, a lot of this into the context of case vignettes, which I think are helpful for these types of discussions. So we'll start with another case and kind of work through this essentially. So we have a 69-year-old man with fatigue, mild night sweats, some weight loss, and abdominal discomfort from having an enlarged spleen. And blood counts show that, the hemoglobin's 9, the white count is a little bit elevated, platelets are slightly low, 2% blasts are noted, and the bone marrow here has 2 plus fibrosis and is consistent with MF. And the genomics show that the patient has a JAK2, ASXL1, and DNMT3A mutations. Cytogenetics show 2 abnormalities, deletion 20q and trisomy 8. So, what's the risk of progression in this patient's disease, and what are the implications of these particular findings for this patient's treatment response, right? So, the points to be made here, and as we'll walk through the slides, are that when we think about a patient who we're seeing perhaps for the first time with MF, really what we want to try to do is understand what this patient's possible course could be. And the data here, John started to talk about this, help us understand that in terms of risk stratification. What risk stratification doesn't tell us is what to do, right? And the question is always, when we think about treatment, do we think about JAK inhibitors? Do we think about other therapies? But the risk stratification isn't going to tell us that. It's really the clinical scenario that's important. But what risk stratification does tell us, as John started talking about, is stem cell transplant, right? If somebody is high enough risk, it is likely worth getting a consultation if the patient is an appropriate candidate for transplant. But that's what the risk stratification helps to tell us. The other thing that's important, though, is the last bullet point here, which is what are the implications for treatment response? Because increasingly these data and the mutation data in particular give us a sense of what is the likelihood of the patient having a sustainable response to therapy. And that by itself could color our decision as to whether or not to, for example, prioritize a patient to a clinical trial up front or early referral to stem cell transplant. So these are the important details that we can discern from a case from simple data like this that's going to inform our sense of where the patient may be going and what are the things we might be able to do, longer term to intervene based on their risk. So MF has a progressive nature. And it's also a spectrum of disease. There are patients with early myelofibrosis, such as pre-fibrotic myelofibrosis, who we kind of think about more like ET patients, right? We think more about the vascular events as the major issue. But then there are the patients who are more, I guess, let's say, symptomatic or have other manifestations, and that includes constitutional symptoms, progressive organomegaly, progressive cytopenias, which are a really big problem. And these are the more complicated patients who ultimately have a worse prognosis. We worry about leukemic transformation. That can occur in up to 25% of patients. And ultimately, most patients with MF are going to, die earlier than their peers who don't have myelofibrosis. So this is a chronic but progressive disease. And as John talked about, we have different ways to prognosticate. We have the IPSS, International Prognostic Scoring System, that's useful, when we're first meeting a patient. And it takes into account age, the presence of symptoms, anemia, elevated white count and blast more than 1%. And this is really the foundation of all of the other models. There is the DIPSS, which has essentially the same variables, but it adds 2 points for hemoglobin less than 10. And as John mentioned, anemia is really one of the driving factors in terms of prognosis of patients. But you see here the utility of using something like the DIPSS. If you look at the splay in the survival curve between intermediate 1 and intermediate 2, these are very different, it can be different patient populations in terms of how they might do. Now, mutations matter, and JAK-STAT mutations drive the disease, and we've known this for quite some time. And these are mutations in JAK2, MPL, and calreticulin. One word of note here is that, depending on the mutation panel you send, it may not capture all the relevant variants. And this is particularly notable for MPL. There's the canonical mutation that causes disease, but there are actually other mutations that are known to cause the disease, and they're not always captured on every single panel. So, if you're dealing with a clinical situation where the patient looks like they have myelofibrosis, but you're not getting, the genomics to support that diagnosis, it's worth going back and considering whether or not the panel that you're using is inclusive enough. Um, unlike ET and PV, MF patients can have multiple mutations. There are patients who have, 3 to 5 mutations, and this does actually become important, and we'll get to that in a moment. But in ET or PV patients, it is much more common that patients only have one mutation. And that does, I think, affect how we think about uh, prognosis in the disease, but also responsiveness to therapy. So, if we think about the mutations that can occur in the disease, this is the spectrum of mutations that have been described in MPNs in general. And again, JAK and calreticulin are the most common. Beyond those are TET2, ASXL1, and DNMT3A mutations. Again, not that common, but they can certainly occur. And then you have a whole host of mutations that occur at a frequency of under 5%. And these are all the typical disease mutations, IDH mutations, RAS mutations, P53, SRSF2. But these things do matter. They do actually inform the prognosis. And as the disease evolves, particularly as the disease gets towards more of an accelerated or blast phase disease, this completely changes. So things like P53 become 30% of mutations in patients in that disease category. SRSF2 and IDH mutations become closer to 20%, right? So the genomics change as the disease changes. On a very simple level, if we think about prognostication based on driver mutation alone, at CALR mutant patients tend to have the best prognosis. The caveat here is that if we go back to a couple of slides earlier, many patients don't just have one mutation. So in a world where you're dealing with patients with one driver mutation, which you can see in myelofibrosis, this is very pertinent information. But what you have to keep in mind is that the presence of other mutations will mitigate the effect of the single driver mutation. An example of this is ASXL1 mutations, which tend to infer a poor prognosis. Apologies for the noise. It's New York City and something's always on fire. Um, but if you have a CALR and an ASXL1 mutation, this curve shifts down, right? So it is not so much about only having one mutation. It is about what is the cumulative effect of having multiple mutations. And this is the thing that one has to keep in mind when thinking about prognosis and to some extent response to therapy. Now, as was discussed earlier, right now there are 4 mutations that we know of that seem to have a bearing on overall prognosis: SRSF2, EZH2, ASXL1, and IDH1 and 2. U2AF1 mutations and RAS pathway mutations are also added to this list currently as having an effect on prognosis, which is negative. These stratification are going to likely change in the next year owing to some new data, which that there's certain combinations of mutations that seem to have a much worse prognosis. But for right now, these are the key things to remember. And RAS mutations are associated with a worse prognosis in part because they confer a resistance to JAK inhibitors. So there is the MIPSS-70 scoring system that takes into account these genomic variables. And again, the clinical variables that are in the scoring system are essentially, similar to what we saw with the IPSS and the DIPSS. But here, the absence of a calreticulin mutation is a negative value, so you get an increase in the hazard ratio. The presence of any of these 4 high-risk mutations adds a concern as well. So this is a very user-friendly system, I think, to use in clinic. If you Google it, it's sort of a list of radio buttons that is something you can do in clinic easily. The one thing to remember is that this scoring system was developed on primary myelofibrosis patients and not on patients with secondary myelofibrosis. So post ET or post PVMF, this is really a scoring system developed in patients with primary myelofibrosis. And you see here how it behaves and what it tells you, right? Which is that if you can really call a patient low risk, their prognosis, over time is really quite distinct from the intermediate high risk or very high risk, right? So that's the first principle. The second principle to me that's important is that the very high risk patients are really high risk, right? These patients have a very poor prognosis. And this really needs to inform how you think about what you're going to do for the patient. And as I mentioned a few moments ago, RAS pathway mutations are really associated with a poor overall survival as well as an increased risk of leukemic transformation. And U2F1 mutations also have a negative prognostic value. And importantly, they are associated with some clinical findings, which are anemia and thrombocytopenia. Okay, so this, as I mentioned, this is the radio buttons for the MIPSS-70. Very, very easy to use in clinic, but the key thing is you have to have the right data, right? So, doing a broader genomic panel makes a difference because if you don't, if you're just doing a driver mutation panel, you're not going to be able to answer this question about HMR. And so I would strongly advocate that, when you are doing your workup of the patient, it is essential to use a broad gene panel. Broad is subject to interpretation, but I would say any panel that goes beyond just the driver mutations. I mean, people sometimes still get the reflex test where if they look for JAK2, if not MPL or calreticulin. I think you have to be broader in this day and age. And does it have to be a panel? No, it doesn't. A lot of the panels that are commercially available are 50 to 60 genes, which capture the essential HMR genes that you want to be able to prognosticate. The other thing is karyotype is really important. There's increasing data that copy number changes really have a prognostic impact in this disease. And we don't always get this from the bone marrow, but this is part of the importance of doing the bone marrow because you're much more likely to be able to do cytogenetics or even fish from the marrow. Okay, so let's go to back to our case, right? So we started with this patient, 69-year-old patient with these three mutations, deletion 20q and trisomy 8. So if we put all of his numbers into our risk calculators, by MIPSS-70, he's high risk with a 5-year overall survival of 5%. And if we use the MIPSS-70 version 2, which takes into account the U2AF1 mutations, he is very high risk with a 10-year overall survival of less than 5%. So in practice, if I was seeing this patient, I would refer this patient to stem cell transplant. We would also think about initiating treatment based on the presence of splenomegaly and symptoms. But again, when you're dealing with a 69-year-old with a 5-year overall survival of 5%, it is, I think, one has to think about stem cell transplant if appropriate. So how we treat the disease depends on what it is we're trying to accomplish. And I think this is one of the most important treatment principles. Having myelofibrosis does not equate to giving JAK inhibitor. I think this is, the JAK inhibitors are very important in this disease, but we always have to step back and say, what are we trying to do here? Now, for things like symptomatic splenomegaly and constitutional symptoms, JAK inhibitors are really our mainstay of therapy, and we have 4 FDA-approved JAK inhibitors in the US. There are other modalities that are sometimes adjunctive and useful, and that can include things like really rarely these days, cladribine, hydroxyurea. If patients have, leukocytosis can be helpful, and splenectomy, which is, I think, increasingly uncommon. Sometimes we will use it in a refractory patient who we're trying to transplant because the size of the spleen actually does correlate with engraftment. But I can think of, at least from my experience at MSK, we've had one splenectomy in the last 8 years. So this is not a common thing. Now, patients with anemia are interesting. There are some patients who have only anemia and they have mild splenomegaly and mild symptoms. This is, I would say, 10 to 20% of patients. In many cases, these are actually U2AF1 mutant patients. And for those patients, JAK inhibitors aren't necessarily your drug of choice. There are older drugs that can be useful, like ESAs, sometimes danazol, sometimes thalidomide or lenalidomide, sometimes luspatercept, which does not have an FDA label in myelofibrosis, but it is in the NCCN guidelines for myelofibrosis. But there are 2 drugs, momelotinib and pacritinib, that can have a anemia benefit, which we'll get into in a moment. For other rare scenarios, sometimes extramedullary hematopoiesis you can see almost anywhere, but sometimes you'll, for example, see this in the lungs, in which low-dose radiation therapy can be helpful. In very early disease, there is some data to support the use of interferons, pegylated interferon, for example, in prefibrotic myelofibrosis. Currently, per ASH clinical guidelines, it is not recommended, but again, there are published data on this, and there is a clinical trial ongoing right now to assess whether or not another interferon called ropeg interferon might actually be useful for patients with prefibrotic MF. But again, the data here is limited. It's a single center. It's limited number of patients. It is there. We still have to worry about thrombosis in these patients like we do with ET and PV. That's not the primary concern, but it is still a concern. And then, of course, transition into accelerator blast phase is very difficult to deal with. Hypomethylating agents tend to be the backbone of our treatment here in combination with ruxolitinib or with venetoclax. The data with HMA and venetoclax in this scenario from three multi-center papers suggest the response rate is about 30 to 40%. So it's not what we see with the de novo AML, from the azacitidine and venetoclax studies. So this is really an area of unmet need. Um, Induction chemotherapy still can be used, but it should really only be reserved for patients without biallelic p53 alterations, and only in those patients for whom curative intent is intended, i.e., patients who will be consolidated with a stem cell transplant. The data actually suggests that in a patient who is not consolidated with stem cell transplant, there is no benefit to giving intensive chemotherapy over a more limited intensity chemotherapy. So we have four FDA-approved JAK inhibitors, and you see these here. Some of these are JAK1 and JAK2 targeted, and some are only really JAK2, and that's pacritinib and fedratinib. And there is some thought that JAK1 inhibition may lead to some of the infectious complications we sometimes see with some JAK inhibitors. Um, and in terms of side effects with all JAK inhibitors, you can see cytopenias. So even though some are more useful than others for cytopenic disease, you can see more suppression with some versus others, but they all can cause anemia and thrombocytopenia. With ruxolitinib, you have to be wary of increased risk of squamous cell carcinoma of the skin. It's only about a 6% incidence, but in our practice, we usually have patients see dermatology once a year. And the second thing you have to be aware of is there is an increased risk of zoster in patients treated with ruxolitinib. And so usually before starting a patient on Rux, we'll make sure that they've had their Shingrix vaccination series. Ruxolitinib and fedratinib are for use for patients with a platelet count of 50,000 and higher. So I would kind of group these as one set of JAK inhibitors, whereas pacritinib and momelotinib can be used with patients with thrombocytopenia. Pacritinib can be used with platelets less than 50,000 without restriction. Platelets can be 5,000, and you can use pacritinib, and that is on label. With momelotinib is approved for patients with anemia, but platelets can be as low as 25,000. In terms of other toxicities to be aware of, fedratinib, as John mentioned, as a black box warning for Wernicke encephalopathy. We tend to often just put people on thiamine. And there is a fair amount of GI toxicity, particularly early on with fedratinib. Pacritinib also causes GI toxicity, but it tends to be limited and occurs over the first couple of weeks. Again, GI prophylaxis for fedratinib and pacritinib is critical. Pacritinib should be stopped before a major surgical procedure per label. And momelotinib has been associated rarely with peripheral neuropathy, but also occasionally with infections. We've also seen patients have vertigo early on. So our practice is often to ask patients to take momelotinib at night before they go to bed, and that seems to help to mitigate this. All right, so briefly going through some of the data supporting these JAK inhibitors. So the COMFORT trials are, now more than a decade old, but they were randomized trials of ruxolitinib versus either placebo or at that time what was best available therapy, which was not a JAK inhibitor. And the endpoints of these studies were spleen size reduction and symptom improvement. And when it came to spleen size reduction, it was very clear that ruxolitinib was superior to placebo, but also importantly, in terms of symptom burden, ruxolitinib clearly reduces the symptom burden to a great extent in patients with myelofibrosis. Long-term survival data, and it's important to remember that survival was a secondary endpoint of the studies, from pooled analysis of COMFORT 1 and 2 showed that the risk of death was reduced by 30% in patients who were randomized to ruxolitinib. Granted, there was crossover here, but there was different modeling used to come up with this data. And the median overall survival with Rux versus control arms in the pooled analysis was 5.3 years versus 3.8 years. So obviously an important modality. And the spleen response does matter. Shrinking the spleen does matter. Now, of course, are you saving people's lives because you're shrinking their spleen? No. But to me, this is an indication of the responsiveness of the disease to the JAK inhibitor. And so reduction in the size of the spleen does correlate with survival. And this is an important concept. And I think, this is spleen by palpation, but I think doing this on a volumetric basis is an important thing. Getting a baseline spleen ultrasound and then doing a follow-up at 4 to 6 months is informative, in terms of how your patient is doing. Now, the Jakarta study was a randomized trial of fedratinib versus placebo. And here there were two different doses of fedratinib used. 400 milligrams is the dose we use in practice, so we're only going to focus on that dose and its results. But here, compared to placebo, if we look at spleen volume reduction, fedratinib was clearly superior. So, as we see with ruxolitinib. And in terms of symptom response, you see that with the dose with fedratinib, scores steadily were reduced versus what was seen with placebo. So again, you're getting a spleen and symptom benefit with fedratinib, similar to what you see with ruxolitinib. Again, the key point with both is that these are for patients with platelets of 50,000 and higher. Okay, so going back to our JAK inhibitors, let's focus now on the JAK inhibitors for patients with lower blood counts. So let's put this into context. So let's take a case two, 76-year-old male, fatigue, weight loss, and abdominal fullness, has a large spleen, but this patient's counts show white count of 2.3, hemoglobin 6.5, and platelets of 41,000. Patient has advanced fibrosis with MF3 fibrosis. Cytogenetics are normal, and the NGS panel shows a JAK2 and an ASXL1 mutation. So these are not the most common patients. I would say this is more akin to about 20% of the MF patients that we see, but these are patients that we do see and do take care of. These are what we call myelodepletive patients. So how do you approach these patients? This is a very difficult thing to have to manage because anemia is a driver of prognosis, but actually so is thrombocytopenia. So this is a very high risk patient. So how do we manage this patient? How do we help this patient? So there's a couple of things to keep in mind here and key points to draw your attention to. If I go back to momelotinib and pacritinib, aside from them having labels for lower platelets, one of the important things is that they both inhibit this ACVR1 pathway. So why do we care about that? Well, there is a current hypothesis that ACVR1 regulates hepcidin, and that momelotinib and pacritinib inhibit the pathway and decrease hepcidin, which thereby increases available iron for erythropoiesis. That's the current working hypothesis. And in fact, both of these drugs do have an anemia benefit. So let's go through some data quickly. With pacritinib has been through a number of phase 3 trials, but one of them was PERSIST-2 here. And PERSIST-2 was a randomized trial of pacritinib to two different doses. We use 200 BID in practice, so let's not focus on the 400. Patients could have been previously treated or be treatment naive. And again, they either received pacritinib or best available therapy, which did include JAK inhibitors. And most commonly, this was ruxolitinib. So there was a comparison here with ruxolitinib. And the co-primary endpoints included SVR 35% response and 50% reduction in TSS. And the baseline characteristics, without getting into the weeds, the one thing I want to draw your attention to is right here. The platelet count of less than 50,000 was about 40%, a little bit over 40% in both arms, right? This is a very different patient population than what I showed you in Comfort and Jakarta. Those patients had to have a platelet count over 100,000. We are dealing with a different patient population here, people who have a profound thrombocytopenia. Now, in the BAT arm, again, most patients receive ruxolitinib, some hydroxyurea, and some older therapies as well. But the bottom line here is in the intention to treat population, pacritinib 200 BID was superior to best available therapy, which again mostly was ruxolitinib, in terms of spleen volume reduction and symptom improvement. And this was statistically significant. And in patients with platelets less than 50,000, the same trend was observed. There was not enough numbers here to make a statistical argument, but at least the same concept holds. So this is a drug that certainly can help patients who are much more cytopenic. Adverse events reported here included, diarrhea in 48% of patients, as well as nausea and vomiting, as well as thrombocytopenia and anemia. So again, it's important to prophylax patients. There was an early concern about bleeding and cardiac events that led to an FDA hold, but subsequent studies and pooled data sort of relieved that concern. And these, of course, are patients who are very thrombocytopenic and anemic. Now, one of the things that I think is interesting, if you look at some of the data from the real world, is that platelet stability over time is something you do see, right? Do you have a marked platelet improvement? Not necessarily. Some people, about 19% of patients on pacritinib will have an improvement in platelets. That's not insignificant, considering that we don't usually use things like romoplastin in myelofibrosis because of concern of stimulating the megakaryocytes that cause disease. So having anything that can help us with platelets is a useful thing. But most often you see stability of platelets with pacritinib. Now, interestingly, in post hoc analysis of this study showed that achieving a spleen volume response by as little as 10% is associated with an overall survival benefit from this study. So again, looking at the spleen volume change does matter. It does give you a sense of where the patient is in their trajectory. But again, reduction of the spleen volume did make a difference for survival. And interestingly, in the BAT arm, this wasn't true, suggesting that there is some other effect that pacritinib is having beyond just spleen volume response. Now, Momentum was a study that led to the approval of momelotinib. And this is a second-line study of patients previously treated with a JAK inhibitor who were symptomatic and anemic. And that's the key thing. They were randomized to momelotinib or danazol. And the endpoint here was a symptom response with other endpoints of spleen and transfusion independence. And the takeaway here is that momelotinib was a better drug for symptoms and spleen response, not surprisingly, but it was non-inferior to danazol, which we've used for years for anemia, with a 30% transfusion independence response rate. So an important point. Now, Momentum was studied in two other phase 3 trials, upfront versus ruxolitinib and second line after ruxolitinib exposure. And these were, I guess these were not successful trials, but there's something to be learned here, which is that, with regards to spleen size reduction, momelotinib was non-inferior to ruxolitinib, so that's important. But with regards to symptom response, momelotinib was inferior to ruxolitinib. And when you're thinking about which drug to use, this can be a useful piece of data to keep in mind. But when it comes to transfusion dependency, this is an important piece, which is that if you look at transfusion independence at baseline in the Simplify 1 study, there were no differences between momelotinib and ruxolitinib. 68% and 70% respectively of momelotinib and ruxolitinib treated patients were transfusion independent. But at week 24, this is no longer the case. 67% of patients who were treated with momelotinib remain transfusion independent versus 49% treated with Rux. So in thinking about what drug to use when, right? I think momelotinib can preserve the hemoglobin in a patient who's very anemic. This is, often our drug of choice. In a patient, who has an enlarged spleen as well, the expectation is that it would do just as well as Rux at reducing the spleen. And similar things were observed with pacritinib. Again, coming back to the principle that it does also inhibit this ACVR1 pathway. Transfusion independence conversion was observed in 37% of patients treated with pacritinib in a post-hoc analysis of the PERSIST-2 study versus 7% with BAT. So both of these drugs can give you an anemia benefit. And if you look at this is data from momelotinib phase 3 studies. If you look at transfusion needs or change in transfusion intensity over time, you see that it's actually quite flat with momelotinib, whereas with ruxolitinib, it increases as we expect, over the first couple of months and then declines over time. So, again, thinking about your patient and how you're treating them, and a patient who is very anemic, this is an important curve to keep in mind as you think about whether or not they're going to be able to get blood transfusions or other supportive measures. So, to summarize, as we're come to time, risk stratification is vitally important in the treatment of patients with MF. It's going to tell you a little bit about how you can expect them to do and maybe where you need to go in terms of transplant or not transplant. And the selection of the right tool for the right patient is important. You want to select the best JAK inhibitor. Now we at least have choices, amongst the JAK inhibitors that we have, and so we can start to tailor the drug selection based on the patient's characteristics. And finally, I would always advocate that clinical trials for both treatment naive and previously treated patients should always be considered. JAK inhibitors are really wonderful, useful drugs, but they are limited. They are limited in their depth and durability of response. And we are in an era where we have multiple clinical trials for patients with MF. And I would certainly recommend that trial always be considered either upfront or at the time of treatment change. So, we will take questions shortly, but let me just go back to the post-test clinical vignette. So again, 76-year-old male has symptoms and an enlarged spleen. Blood count show a white count of 9.5. Hemoglobin is 10.5 grams per deciliter, or here 105 grams per liter. Platelets are 181. This patient has primary myelofibrosis and is symptomatic. So which would be the right drug in this patient? Lenalidomide and prednisone, pegylated interferon, fedratinib, ruxolitinib, pacritinib, or either C or D. Remembering as we discuss the labeling of the drugs. Okay. So ruxolitinib or C or D. So the answer in this case would be C or D. Remember, the patient's platelets are 181 in this case, and the patient is eligible for a JAK inhibitor based on spleen and symptoms. And so per label, you could use either fedratinib or ruxolitinib. Pacritinib would not be your choice here because of the platelet count. And the patient has, more advanced disease and is not likely going to benefit from interferon or lenalidomide prednisone. Okay, I guess we're open for questions.
So, Reggie, thanks for great presentation. I think we have time for one question. There's a question in the chat box. How frequently are newer JAK inhibitors used in treating myelofibrosis in the community heme practice, or is it reserved for tertiary medical centers? What do you think about that?
I think that, we've actually seen a widespread uptake of the newer JAK inhibitors in practice, and the patients we see in collaboration with community practitioners. It's interesting. I think there's been pretty nice uptake of some of these newer JAK inhibitors. Again, I think the important thing is going back to the principle of, we're in an era where we can select a drug that perhaps better suits our patients. It's good to see that.
All right, I would totally agree with that. And can you just advance? You have control of the slides. Can you just advance the slides? I just want to make sure that,
Yeah.
yeah, that the participants are aware. Please, complete the survey in order to get your CME and CE certification. The link is provided at the conclusion of this program, and should be emailed to you as well. And please do this before June 13th of next year in order to get that credit. And then the next slide, Reggie. So, on behalf of the team at CancerNet and myself and Dr. Ron Paul, we thank you for your participation and attendance today's CME program and look forward to further engagements. Thank you.
Thank you.